What's been transformative for the management of large cell lymphoma is CAR T-cell therapy for chemo-refractory patients, and there's 2 FDA-approved products in that setting. However, what's challenging is these patients have failed at least 2 prior systemic therapies, so the time from manufacturing to delivery of cells can be a very scary time for most clinicians. So there are a number of questions as to how can we adequately bridge these patients, because we know if you go into CAR T-cell treatment with high tumor burden and high LDH, you may experience more in the way of cytokine release syndrome and neurotoxicity. So ideally we would like to debulk these patients going into CAR T-cell therapy, and we've failed to identify a strategy that would be effective in that setting because again they failed at least 2 prior lines of therapy. There was an abstract here presented by Mike Jane, which was a consortium of almost 300 patients, again looking at bridging and axi-cel treated patients, and did not identify a preferred bridging strategy, and also identified that those patients suffered worse outcomes, meaning higher risk of death in those who were bridged versus those that were not, albeit differences in baseline characteristics. So we have single-center data presented at this meeting with 125 patients who received standard of care axi-cel, and we looked at our bridging approaches. And what we found is radiotherapy tended to have better outcomes for those patients. Now this is single-center data with all of the selection bias that exists. However, what this suggests is that you might be able to mitigate some of the toxicity seen with systemic therapy in patients who've had at least 2 prior lines of treatment by using radiation, again, to debulk and minimize their risk of additional systemic therapy exposure. So again, I think this needs further exploration in a multi-center setting. So in large cell lymphoma, where does CAR T-cell therapy have its optimal place? Right now it's approved for patients who failed at least 2 prior lines of therapy, and that was the highest unmet need because prior to CAR T-cell therapy, those patients were facing an overall survival of about 6 months or less. So again, we have 2 FDA-approved products in that setting. It makes perfect sense to move it into earlier lines of treatment. So we have 3 randomized studies right now underway looking at CAR T-cell therapy versus salvage chemotherapy and high-dose therapy in the setting of chemo-sensitive disease. Now these are in patients that are high risk, meaning they were primary refractory to frontline R-CHOP-like therapy or progressed within 12 months. Because we know based off the CORAL study that only 20% of those patients do well with standard therapy. So we're eagerly awaiting the results of those randomized studies, because if they're positive, then you'll see CAR T move into second-line treatment. There are also patients that progress very rapidly through frontline, and sometimes you can't get them onto these prospective studies because they're progressing too quickly to await the manufacturing and the screening tests. So can we even look at it into earlier, meaning after they are progressing in the midst of frontline treatment? So there is a ZUMA 12 study looking at patients. They're high risk, again, so double hit, high-grade lymphoma, or high IPI that progress even after 2 cycles of frontline R-CHOP-like therapy. So again, I think it will continue to move into earlier lines of therapy, but it will be reserved for patients that are chemo refractory.